Well, I welcome everyone back. We're going to move from discussing the routes of exposure to talking about clinical principles for advising patients on how to reduce exposure. I'm really pleased to introduce the moderator for this session, Brian Lind. He is the Associate Program Director of the Yale Occupational and Environmental Medicine Program and Chief of Occupational Health Services at the VA Connecticut Healthcare System. As the Associate Program Director of the Yale Occupational and Environmental Medicine Program, he oversees the medical education and training for the physicians in training in occupational and environmental medicine. He has also designed curricula to train internal medicine residents in core aspects of occupational and environmental medicine. As Chief of Occupational Health Services at the VA Connecticut Healthcare System, he oversees the Medical Center Occupational Health Services for over 3,000 employees in the VA Connecticut Healthcare System. Here, services include medical surveillance, work injury evaluation and management, infection prevention, and employee health and well-being. As a board-certified occupational and environmental physician, he also provides patient consultations to evaluate health effects of occupational and environmental exposures. Dr. Lind received his MPH in Occupational and Environmental Medicine from the Yale School of Public Health and his MD from Albert Einstein College of Medicine, Yeshiva University. I'd like to turn things over to you, Brian.
Okay, thank you very much, Ned, and it's really my pleasure to introduce our speaker and panelists for the second session this afternoon. And so I will begin by introducing Dr. Sheila Satyanarayana. Dr. Satyanarayana is a professor of pediatrics and adjunct professor within the Department of Environmental and Occupational Health Sciences at the University of Washington and the Seattle Children's Research Institute. Her research interests focus on exposures to endocrine disrupting chemicals and their impact on perinatal and child health. Dr. Satyanarayana serves as the PI for the Infant Development and Environment Study. She is a co-principal investigator for the NIH Environmental Factors Affecting Children Health Outcomes Pathway Study at the University of Washington and the Seattle Children's Research Institute. The study combines 3 cohorts, GAPS, TIDES, and CANDLE, to examine environmental exposures, the placental transcriptome, and child health outcomes. She served as past chair of the United States Environmental Protection Agency's Children's Health Protection Advisory Committee, and as well as on the National Academies of Sciences National Research Council Committee on Endocrine-Related Low-Dose Toxicity. She currently serves on the US EPA's Scientific Advisory Committee on Chemicals for the Toxic Substances Control Act, and she practices medicine at the University of Washington Medical Center as medical director of the newborn nursery. And so our format for this session will be similar to last time. We'll start with a presentation, brief period for Q&A, and then we'll introduce the panel and have a further discussion. So without further ado, Dr. Satyanarayana, welcome.
Thanks. Thanks for that introduction. And I want to thank the organizers for inviting me here. I will start by sharing my slides. All right. Can everyone see that in presentation mode? Okay, great. So I will just start by saying that I am not an expert in PFAS chemicals, but I have participated in small research studies on PFAS chemicals, and actually this presentation combines my expertise in newborn health and pediatric environmental health with some of my research efforts. So I'm very pleased to share these slides with you. So first I'll be talking about our small study on PFAS in breast milk, and then clinical perspectives in exposure reduction. So first for this study, this is definitely a combined effort. I was asked to participate by Amina Salamova and Erica Schrader. And Amina is at Indiana University and performed all the lab analyses associated with the study. And Erica Schrader is in Washington State, where I am, and she works with Toxic Free Future and was involved with a lot of the analysis. So I don't need to explain to this crowd where PFAS originate from and how we're exposed, but it really derives from this manufacturing process into products and then product use at the consumer level. And that's really where consumers are exposed and kind of the population that I work with, mothers and infants. And then, of course, you have product disposal and it's put back into the life cycle, biological life cycle, where you can have continued exposures. So there are exposures from multiple sources and routes for pregnant women and women who are breastfeeding. And here you can see multiple that are circled, potentially a raincoat, some stain-resistant carpet, similar fabric from a sofa, food, and also drinking water. And all of these may be sources of exposure for this breastfeeding mom. So in terms of this study, we know that early life exposure may lead to adverse effects in later life from PFAS. We do know that breastfeeding exposure is an important pathway, important route of exposure. And the last two studies on PFAS in breast milk from the US really date back to 2004. So this is one of the few studies that is current. There are more recent studies from Asia that have reported the buildup of current use PFAS, meaning the shorter chain PFAS chemicals. So in Washington State, we recruited 50 first-time moms residing in and near Seattle. This was really a convenient sample. Our outreach was via parenting groups, social media, and flyers. The moms were asked to manually express 50 mLs into a glass container, and researchers collected milk within 24 hours and maintained frozen samples until shipment for analysis. In terms of the demographics, the women were 95% Caucasian. The mean age was 34 years. They had resided in Washington State for about 13 years, and many of them had higher education, the majority did, and 82% lived in middle class or upper middle class neighborhoods. So definitely a high SES, primarily white cohort. So samples were analyzed with LC-MS for 39 PFAS compounds, PFAS and PFOA, the long chain compounds, short chain compounds, as well as PFAS precursors. So obviously I won't be presenting all of the results from this study, but you can see them in this citation here. So the PFAS chemicals were detected in 100% of samples that were collected. There were 16 PFAS total detected, 12 were detected in more than 50% of samples, and ranged from 52 to 1580 picograms per ml. And here you can see a pie chart of the breakdown of concentrations. So the majority are in the 100 to 299 picograms per ml. In terms of what we found, the main take-home point here is that the current use PFAS are abundant in breast milk. So the CA compounds are the traditional PFAS and PFOA compounds that you can see here. Then there are the long chain on the right-hand side, and then there are the shorter chain over here. Again, the N is 50, and this is the detection frequency, which was 70 to 100%. And this was in picograms per ml. So one of the things that we did was to estimate the daily intake for an infant just from breast milk. So it's important to remember that this is not including all the other potential sources of exposure. But if you just try to estimate the sources from breast milk only and making the assumption that the infants are getting exclusive breast milk as a primary dietary source, you can see here that the RFD for New Jersey for PFAS is here. The adult dietary EDI, estimated dietary intake, is here. And then the red is an infant that's less than 1 month old, orange 1 to 3 months, and so on. And you can see that for PFAS, it's exceeded at all of these different ages. And as you get into some of these other chemicals, It gets close to the adult dietary guidelines, and some of these get close to the New Jersey PFAS RFD, and here is the federal level. So I said that there were other studies here in terms of breast milk, but they're few and far between. And here you can see that in terms of the detection frequency for some of these C8 compounds, they were 96 and 80% in a previous study. And then in our study, which was really, the samples were collected and analyzed in 2019, they were 186%, so very similar. What is not similar is in some of these other compounds below the C7 to C12, you can see that they are about 6.7%, 2.2%, 64% here. And in our study, we had them at higher percentages, but I think what's important to remember here is that the limit of detection was much higher in previous studies. And so it may have been that these concentrations were higher, would have been higher if we had a lower limit of detection. And of course, the technology evolves and we're able to detect at lower limits as we move forward. In terms of global temporal trends, I think we've talked about and heard that the PFAS and PFOA detections are the concentrations, biomonitoring concentrations are decreasing over time. This is just a plot of many different studies over time for the PFAS and PFOA chemicals. And then here for the C4 to C7 PFAS chemicals, this is a detection frequency, not a concentration. You can see that the detection frequencies have increased over time. But here again, there weren't very many studies before recent ones where they were trying to detect these. So in terms of the summary from this very small study, we found that both current use and legacy PFAS are abundant in breast milk from US mothers. And while levels for legacy PFAS are going down, the detection of current use short-chain PFAS is going up. And consistent biomonitoring of breast milk would be needed to be able to detect changes in exposure patterns over time. And in general, more studies are needed to determine potential health impacts from breast milk exposure. And that's something I'll talk about a little bit more as we transition to the second part of this talk. So in terms of breast milk benefits, this is something I talk about a lot as when I work in the newborn nursery with first-time moms to try to encourage breastfeeding. We know that breast milk has a number of immune factors that include cytokines and immunoglobulins that directly and immediately fight infection. Recent studies show that that breastfeeding can reduce the risk of ear infections by 50% with 5 months of exclusive breastfeeding, or respiratory infections by 72% with 4 months of exclusive breastfeeding. So those are really significant reductions in infection risk for these newborns. There's also better behavioral development that's observed, increased IQ, better school readiness linked with breastfeedings. There's some evidence for improvement in allergies, obesity, and gastrointestinal disease, and I lump those together because there's not a significant amount of evidence for those outcomes as there is for the immune and infection risk, but certainly it does exist. And then there's maternal benefits of breastfeeding, of a reduced risk of breast and ovarian cancer, as well as bonding, which is not a direct milk benefit, but it does improve infant outcomes. And the recommendation from the American Academy of Pediatrics is exclusive breastfeeding for at least 6 months. And this has not changed for a number of years now. So chemicals in breast milk and health impacts, there are many studies with small numbers of participants that report a variety of chemical exposures in breast milk, but there are very few studies relating breast milk chemical exposure with health outcomes. There's one that I note here that looked at PCBs from 1977, and this was a major contamination event that occurred in Japan. And they did note in this study that the that PCBs in breast milk and breastfeeding was associated with a lack of endurance, hypotonia, expressionless faces in the infants, and also significant effects in the mother from this contamination event. But that is one of the few studies that's really shown significant health outcomes, specifically with breast milk exposure. There are a lot of studies that show when there are contamination events with in pregnancy and with in utero exposure, there are significant birth defects and health outcomes, but not as many with breast milk. And often pregnancy biomarkers are used as a proxy for breast milk exposures, but I think we all know that the newborn and infancy period is really a different developmental and susceptibility time period compared to in utero development, and it may be just as significant and just as important. We also do know that from current evidence that PFOA and PFOS do suppress antibody response, and that's the immunoglobulin response, as well as natural killer cell response. So those are both immune factors. But breast milk also has other immune factors besides antibodies and natural killer cells. They also have the cytokines that exist that are important. One other thing that we do know from current evidence is that infants who are exposed to lipophilic persistent chemicals have higher concentrations of these in their bodies than infants who consume formula. And modeling that was noted in a paper that I think Judy LeKind is on the panel for this session, and she was one of the co-authors of this paper, showed that there is a decrease in these chemical exposures after cessation of breastfeeding for lipophilic chemicals specifically. So this may not be directly relevant to PFAS chemicals because they're not as lipophilic as PCBs, but we do see some similar patterns with the PFAS chemicals. So to move on to messaging to new moms, this was kind of the charge that I heard from the organizers, is really what do we tell new moms? And this is something that we struggle with often in risk communication and specifically environmental health risk communication. So one thing to note that I've already heard from some of you is that there really are no evidence-based guidelines that are simple for consumers to implement to reduce exposures. And in other words, there are no studies that show certain guidance will actually reduce exposures. So we may know about all these different sources of exposure, but there's really no studies putting those sources of exposure into an intervention model to show that it will truly reduce exposure. And I want to emphasize this point because I've worked on intervention studies before, and those of us who do this kind of research in environmental health know it is very hard to reduce exposures and to certainly show that you can in a research setting. And often the studies that do use very controlled methods where they're either providing products or they're controlling diets of families. So not something that's very easy to implement in the general population. But nevertheless, we do know about sources of exposure. Families can perform water filtration or consume filtered water. This is not my favorite recommendation because it is expensive and it's hard for people to implement unless they are in an exposed area where they are given filtered water already or provided that. They can avoid stain repellents on carpets, clothing, and fabrics, also hard to implement. These next two are a little easier to avoid grease or oil-based packaging for foods like pizza or other similar foods, to avoid nonstick coatings on pans. In a highly exposed population, you can use pre-mixed baby formula or use filtered water to reconstitute formula. You can also check fish advisories in your areas where waters may be contaminated, as well as state guidance on PFAS exposure in drinking water. One thing I do want to note here is that in our environmental health specialty unit, we do give presentations to highly exposed families. So our colleagues have presented to specifically a population in Spokane, Washington, where there was PFAS contamination from an Air Force base. And these are some of the guidance pieces that are given to those communities. So this is truly what's used on the ground. So overall, the goal is to reduce fear and to provide reassurance. And I put this little scale here where I'm looking at benefit and risk of breastfeeding, because I think the consensus is really there's still more benefit than risk from contamination of these kinds of chemicals to breastfeeding. So breast milk is still best based on immune protection, reduced infection, and associated with positive health outcomes in infancy and early childhood. And so I did note that PFAS and PFOA specifically decrease antibody response. So certainly there is the potential for reduced immune response with PFAS exposure based on current evidence, but it's unlikely that these exposures would erase all immune benefit. And I think that's how I like to think about it, is that breast milk can provide significant immune benefit. And do these chemicals really take away that entire benefit? There's no evidence to show that yet. And just being a clinician in this field, I think it's highly unlikely that it erases all immune benefit. The other message that I like to give families is that there's no zero exposure. And this is really to try to take away anxiety and worry from people, because I think pregnant women really want to provide the best environment for their developing fetus and babies to be, and they want to do what's best for them. And we can't really get to zero exposure in the industrialized world that we live in. Overall, we can try to work on reducing environmental exposures through a number of means. And so we talk about eating fresh and varied food diets. So that variation is pretty important, not eating the same, for example, fish every single day, trying to vary your diet to reduce exposures, taking your shoes off when you enter the home, keeping your home dust-free, and then using products low in toxic chemicals and trying to check labels if you can. So I want to switch gears here to talk about clinician training and approach, because I think Ms. Amico presented at the very beginning about the need for important information and how the CDC always says talk to your provider if you're concerned. And so I just want to give a lay of the land of what providers know and what they can and cannot do. So let's just take a general practitioner who's a general physician, pediatrician trained, let's say. They are not trained in environmental chemical exposures and health outcomes. There are very few medical schools that train on any aspect of this, and those that do tend to focus on chemicals that have a very large, strong evidence base over a number of years, like lead exposure or mercury exposure, but not some of these newer chemicals that we are just learning about in the past decade. They are often looking for good sources of information and guidance. So they are really looking to state health professionals, to the epidemiologists, to provide them with information to give to families. One important piece here, and it's kind of part of the training, is that they'll often only use and rely on evidence-based guidance from professional organizations or trusted persons in the field, meaning, public health professionals at the state level or physicians and physician groups. They don't want to test patients unless data will be meaningful and guide counseling. And we see this often when we talk to exposed communities, is that they want testing, and we really grapple with, will that testing be meaningful? And what will we do with the results? And so many primary physicians just will say, we're not going to test and don't recommend people for testing. And they often would prefer to refer or defer to others. But sometimes, unfortunately, there are physicians who do give non-informed advice just because they do not know the information about any of these chemicals. And again, I think I talked about they rely on state and federal public health guidance. The other group of practitioners that people often go to are naturopaths. And I work in the Pacific Northwest, and so I see this a lot. Naturopaths do have some limited training in environmental chemical exposures and health outcomes. They tend to recommend broad testing, and sometimes they may recommend treatment approaches that are unorthodox or may cause harm. But I think what you can see here in both of these categories is that these practitioners are not trained in reading and interpreting research. And that is really what's needed to provide appropriate guidance. So when you do have environmental health trained clinicians, this often requires a fellowship beyond a medical degree. There's the adult occupational environmental medicine training, which is a major focus on occupational exposures, but also does environmental exposures, other non-occupational environmental exposures as well. And there is an accreditation for this, which is great. In the pediatric side, there's not. There's a very small number of clinicians who are really trained in this area, likely less than 200 in the country. And there's no accredited program specifically for this. So for someone like me, I did a fellowship right after residency that focused on environmental health, and then started my research career. But it was a general pediatrics fellowship where I just happened to focus on environmental health. These clinicians are trained in how to read and interpret scientific study. They often have research programs of their own, and they conduct training for other clinicians through something like the pediatric environmental health specialty units or other mechanisms. And they tend to work very closely with public health officials at the state and federal level on medical guidance on contamination events. And in terms of environmental health risk communication, I think what we know is that there's some basic points here to this kind of communication, is that it's often a transdisciplinary effort. It is not done alone by one field. You have to rely on others' great data. You know, the presentation before that provided so much great data. You have to kind of know all of the different pieces to come together. And that transdisciplinary effort requires a lot of time, frankly, to come to a good risk communication points. It requires some public health training, or at least essentials in public health principles, a need to balance risk and benefits. And then in the community and with media, the ability to know your subject matter really thoroughly, which primary physicians will not know the subject matter thoroughly. Also to be very credible, to show respect to every different stakeholder involved, and empathy, and be non-biased in our communication. These are the environmental health specialty units that I spoke of. These are sponsored by the CDC and EPA. There's a network across the country of this, each within one CDC region. And ours is based in the Northwest, and we cover Washington, Oregon, Idaho, and Alaska. And we provide free consultation, referral, and outreach to public health departments, clinicians, healthcare professionals, and as well as communities and sometimes individuals. But although this is a very well networked group of units and they provide very important education and guidance, there's very low funding for this. So it would be very hard to provide education at the individual level. Often we try to train trainers when we're working in this setting. So with that, I just want to acknowledge collaborators on the research, our study participants, and the Environmental Health Specialty Network. Thank you.
Okay, thank you very much. This is a great presentation, and we have just a couple minutes now for folks to ask questions, and I'll start. So I know you've done, the research study involving PFAS in breast milk, and you also mentioned, your clinical work. So I'm wondering, in your clinical work, if you have encountered questions from new moms about PFAS in their breast milk and concerns about breastfeeding, and if so, how you counseled them. So
I haven't encountered those specific questions about specifically PFAS, but more what I encounter is women who say they know there's all these different chemicals that they could be exposed to, and they're wondering what they should focus on to reduce harm for their infant. And they're, in general, those kinds of families and patients are very overwhelmed by what's out there and what to do. And that gets back to that point of, with these kinds of chemicals, is we really put the burden back on the consumer and the individual, which is unfortunate. And so I just try to go back to those messages that were in the slides that we won't get to zero exposure, but we do know how to reduce exposures overall. Here's some good tips for that. And I really try to emphasize that having a good home environment, a supportive home environment, is probably the best thing that you can do for child and infant development. So to try to emphasize the positive things that we can change and have the power or control to change.
Excellent. Do we have any other questions from the group?
I have a question.
Go for it.
Thank you for allowing me to participate today, and I really enjoyed the presentation. I'd like to address Dr. Sheila that I am a doctor of naturopath, and actually very active in my community right now, which we are under a environmental health study, and very impacted I was personally, but I wanted to just touch base that I agree that most of the naturopaths, I think we do get some training of toxicity, toxic burdens and that. But actually my focus is in methylations pathways, especially with my little people that I see as clients. One of the first things that I like to look at, and I don't think Western medicine really even knows much about it, that I've seen yet in exposure, is the mutations in such as the MTHFR mutations, and the child or the parent's ability, right, to fight off or to methylate anything in exposure that they would come into contact with. And I probably one of my questions that I would address is, I just recently got crowned Mrs. United States, Great Lakes of Michigan. And my platform this year is going to be at a national and international level about environmental contamination awareness, because I believe that knowledge is power. And I'm excited today to participate in this webinar, because really, truly, mothers, they're so overwhelmed, the first time being a mom, or they want to do everything right. And yet we're learning so much, especially Michigan, where I'm from. This is a leading state right now for, testing and, education. And I wonder, what could you recommend to me as a doctor of naturopath to the young moms that I see, or how I can make a better impact in my area? Because methylation and pathways is really intriguing to me, and that's where my focus is.
Thank you. Let us know. We just have 1 minute left in this section, so.
Sure. I could just give like a very small answer to that, a short answer. So thanks for being here. And I think that methylation pathways is probably one of the newer areas, and we'll learn a lot more about that. In terms of recommendations, the UCSF group, the pre-group led by Tracy Woodruff, has put together some great materials that clinicians can use. And I would recommend using those. I also think the pediatric environmental health specialty units have put together some great handouts, including those on PFAS. Region 3 specifically has some on PFAS chemicals. So I specifically would recommend those pieces.